So, have you ever been to a presentation or a conference or a meeting where someone showed this great set of slides? They declared success for their program. And yet, if you talk to them later or found out what was going on a few months later, you realize that the program has been scaled back and many of the positions have terminated. This happens all the time in healthcare. So, why? I'm Bruce Spurlock, a physician and healthcare leader committed to helping decision makers and professionals navigate change with clarity. On viral healthcare, we look at the ideas and spreading across healthcare and what it takes to implement them wisely and sustainably. So today we're going to talk about a systematic way to think about healthcare decision making and decision making in general, whether you're in healthcare or not. It works in a lot of different settings and has been studied in all these different environments. But let's go back to the basics. What's the problem? The problem is that decision making for a lot of leaders feels intuitive, but there are flaws in the way we humans think, in the way we humans were designed. So most leaders think about this like, I've been in this long enough. I trust my judgment. And if you imagine yourself, if you're one of the more experienced senior leaders that have been around a while, you probably have this sense even more. And yes, while you do have certain capabilities, experiences, and intuition that's been carved with time to make it better, we still have the same emotional, psychological, cognitive traps that happen. So we're all subject to biases. There's been a lot of research and discussion about it. A couple of the examples we talk about confirmation bias. So we look for things that confirm what we already believe and think. Narrow framing, we only look at either or questions. We don't actually broaden the question about what we're trying to decide between. We have a lot of overconfidence. I like to say people can overestimate what you can accomplish in a year and underestimate what you can accomplish in 5 to 10 years. And we have this short-term thinking because, the world is changing fast. We got to keep up. We have to get the successes right away. So it's kind of interesting to see those biases that we're all sort of built with, we're all designed with. And then I went out and tried to do some research and looking at what are the rates of success and failure with major decisions. We're not talking minor ones, but there are substantial ones that take time and thought and energy that the organization goes under. And here's kind of what I found. If we look just in healthcare at some major strategy, like should we enter a market? Should we grow a market? Should we transform our system and become a different organization or fundamentally operating in a different way? The approximate success rate for that is like 20 to 40%, less than 50%. Should we grow a new service line or add a new service line? The success rate for a service line changes is around 30 to 50%. How about let's join a payment model? Let's try one of these alternative payment models. The participation success rate of those early on, especially, were 25 to 40%. How about operational redesign? Let's change how we staff. Let's organize flow differently in our organization. Those are a little bit better, somewhere between 40 and 60%. How about technology implementations? If we think about success as like, did it achieve our objectives or did it achieve enough of our objectives? Even there, it's around 30 to 60%. So it's interesting, if you go back and stand back and look at all the data, it suggests that somewhere between 1 and 2 of the interventions that you do, 1 out of 2, is not going to work. 50% is probably a high success rate for thinking about it. We have to bat better than 500 in this game of decision making. So here's the key idea to remember. Good people plus experience does not generate consistently good decisions. Healthcare suffers from systematically biased decision environments. Yeah, I think it's just sort of the nature of healthcare, the nature of the way we're constructed as an industry causes a lot of problems. So what can you do about it? I've talked about this a little bit before, but I want to bring in a book that Chip and Dan Heath did. These are business professors, one's at Stanford, the other's at Duke. They wrote this book called Decisive, and they came up with this technology, this methodology that they call RAP. We'll break it down in a little bit, but it's designed to counter common decision-making errors, these challenges that we all face. Doesn't matter if you're super experienced or super junior, it just the way we're built and how do we overcome some of those problems. So let's break down RAP. So the W in RAP stands for widen your options. The R for wrap is reality test your assumptions. The A is to attain distance before deciding. And the P is prepare to be wrong. So super simple, but surprisingly really powerful when you just break down decision making into a series of steps or processes that you can get your arms around. So let's break each one of these things down. Let's talk about W, widen your options. And this one, as a clinician, I like. Here's the common mistake. We often think, is it this or is it that? Do we do this or we do that? And oftentimes it's binary thinking, this yes or no, or pros and cons approach that came, I think, from Ben Franklin way back in the day, is really kind of holds us back. And as a clinician, we were trained to think about things in terms of differential diagnosis. In other words, like here's a list of possibilities, and yeah, I'm going to put one higher on the list as being more probable, but there's still other things that as I learn more, as I go further down the process, I better not exclude. This gets rid of that sort of confirmation bias we talked about. So a better approach, and what the Heath brothers talk about, is widen your options. What are 3 to 5 potential paths? Not just either or, but what, and maybe there are hybrid options. Can we do part of this and part of that? Can we take the best portions of this and do it? Sometimes that works, sometimes it doesn't. We're going to talk about that on a future episode about taking just pieces of a puzzle and thinking that we're really making a difference. But let me give a couple of examples. Let's say we're asking the question of, do we develop a new business line, so we need to hire or don't hire? I mean, part of the problem is we're just asking the wrong question. And today, instead of saying, should we hire or not hire, it's like, is there a way to gain confidence about it? Could we do a pilot program? Could we look somewhere else that somebody has a pilot program? Or could we outsource or purchase temporarily while we're trying to figure out what it takes organizationally to do? So yeah, it'll be a little bit more expensive if we outsource. Yeah, it will take us out of the day-to-day control, but maybe that's a good way for us to test in our marketplace whether this makes sense, to get some more confidence, so that's not just an either or decision. Or if we have to only have an either or way of looking at it, that we've really considered options more carefully. Instead of hire or don't hire, I talk about this all the time with primary care physicians. There are so many people and organizations and states out trying to hire primary care physicians, and we just don't have enough of them. And the sad part is, we're not getting any more. So how do we solve the problem? Do we go out and have these big recruiting campaigns? There's a lot of money in the Rural Health Transformation Program going after this. They're all going after the same diminishing pool of primary care physicians. So is there a way we could like redesign workflow like open access or instant access, where we actually increase the access to a physician, a primary care physician, without increasing the numbers? Or are there ways we can take off some of the ministerial things like medication refills or some of those things, that we can create systems that will be able to do that in a way that's more efficient? So there are a lot of things we can think about as long as we get widening our perspective. Think of it like a differential diagnosis. What are the possibilities? Yeah, this one might not look as appealing now, but I'm going to leave it on the list because it might rise as we gain more experience, as we go down the decision-making pathway, as we learn from other organizations like ourselves. So that's W, widen your options. R is for reality test your assumptions. So this one is part of the problem, that we tend to believe our own narrative, that we look for confirming evidence when we get anchored, or we get hooked onto something that sounds pretty cool, when we get emotionally involved, when we think others are doing it, we tend to find ways to prove that it's likely to work in our organization. So we need to step back for a second and say, why might we be wrong? What evidence could we look for? This is what I talked on the last episode about, really trying to go after ways to prove yourself wrong on this. That's really part of what you're doing with that. Or I do this pretty often. I try to find out like who disagrees. Where's the controversy? If I understand the controversy, if I understand the pros and cons from real people who've really dealt with this, I'm better able to make a decision. So the tool to be able to do all this well is to talk to others. I talked about last time about phoning a friend. That's important to sort of say, first of all, if I can find somebody who's done it that looks like me, but secondly, if I can find somebody who hasn't done it and failed, to understand those processes and then match it to the capabilities of our organization. So sometimes I spend a lot of time trying to dig through reports, doing searches, trying to figure out where a failure happen, because that's the real gold that's out there. And then we've talked about this a number of times. Look at real data, not projections, and data that's meaningful, not just ones about the actions they've taken, but the outcomes and the real results and the results that are translatable to your settings. So this is a really good example of phoning a friend, like we talked about on our last episode. All right, so that's the reality test your assumption they are. Number 4 is the A, attain distance before deciding. And so this is pretty cool to think about this. Part of what happens is we're emotional human beings. We're wired that way, where we have this fight or flight response that clicks on really quickly, whether we want to or not. Our brain is wired to anticipate where it needs to move quickly. And that's also connected to the limbic part of our brain, that emotional. And those emotional memories in particular come to the forefront the fastest. So what we find a lot of times is that emotional desire to make decisions rapidly. We feel there's a pressure to make these decisions, to make them correctly, but like time's ticking. And every day I don't make this decision, I'm hurting the organization. So this notion of emotion plus urgency often leads to poor judgment. So how do we avoid this? There's a lot to this. You can read in their book, the Heath's book on decisive, more depth. I'm not going to be able to give the depth that they do on this, but a common question is like, what would I advise a colleague about this? So if I'm talking to another friend, would I be all positive, 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 or would I be realistic and say, if your organization doesn't have this, this, or this, or if you're not ready for these kinds of components of the implementation of an idea, that might be something that you then focus back on yourself. Am I really able to do these kinds of things? How about this question? How will I feel about this in 6 months? So this is this idea that you're going to stand back and say, 6 months from now, will I be able to really be effective? We talked a little bit about this on the pre-mortem, and I'll do that a little bit more in a minute. But this is more about getting this time. If we waited 6 months, how would I be able to approach it? Would I do something differently? Here's the third technique that I recommend for attaining distance is asking the question, and we've talked about this before, what needs to stop before proceeding? And this one, to me, is the really, where the bulk of the good answers are. What needs to stop before proceeding? I had a friend once who was an executive in a large organization, and he said he was really, really busy. One day he comes into my office and he said, I just got appointed to this major task force at corporate that's going to completely redesign how the organization is operating, so that in 2 years from now we'll be in a completely different, and it's going to take 3 to 6 months, and I'm on a task force, and I'm super excited that they picked me. I feel honored. So I said, how much time is it going to take? And he said, it's probably going to take about 25% of my time. So I asked him, like, okay, like, what are you going to stop? What are you not going to do? Or what are you going to deprioritize? And he said nothing. So I like, okay, really, for 3 to 6 months, you're going to spend 25% of your time more, and you're already working 50, 60 hours a week. I mean, that's just the death march. That's not realistic. And when you frame it like, what will I stop doing? Suddenly you say, is this more important than that? Or what are the trade-offs that we're dealing with? And what's more valuable to the organization? It's an important step that distance improves clarity. All right, the last one is P, prepare to be wrong. We've addressed a lot of this in episode 8. So this is where most leaders struggle. Instead of saying, I'm really confident. In fact, you probably have to present to the board or to senior leadership, we're really confident that this will work. And sometimes that's really not the right question. The right question is, if this doesn't work, what are our options? What can we do if it doesn't work? We should prepare that if it fails, we have contingencies, we have alternatives, we have another direction that can get our organization where we're trying to go. We talked about tripwires. We talked about pre-mortem thinking. This is where, in this liminal space before you launch, you actually force yourself to say, I'm going to fail, and we're going to be wrong. And what am I going to do then? And how am I going to prepare for those kinds of things? And, you don't have to spend hours and hours, but you should emotionally, cognitively set your time and your mood in that place where you think about being prepared to be wrong. So the big takeaway from all of this is you don't need more consultants. You don't need more opinions unless they're from somebody outside the organization that you're seeking. You don't really need more time. What you need is a better process for thinking. You need a better batting average. If the studies suggest that at least only 50% succeed, and maybe less in certain circumstances are successful in achieving meaningful improvement in an organization, you need a better batting average. And the way the batting average works is by being systematic about it, by stepping back and going through a process that's well described. The RAP process isn't the only one. There are many others in the literature and in the psychology and business management research that does. But the RAP one sort of simplifies it in a way for me that gets my arms easier to get around it, to think about the processes that I'm involved. And really, we're never going to be batting 1,000 or figuring it out 100%. We're going to fail. Good ideas always fail in healthcare. That doesn't make them a bad idea. That just means that the execution, the timing, the implementation, the context wasn't really correct for that environment. But good ideas still are successful. So here's my call to action. If this episode resonated with you, take a moment to pause before the next idea gains too much traction in your organization, gets too deeply embedded emotionally, because once you're down there in that emotional space, it's really hard to let go. Ask better questions. I gave you a handful today to think about. Invite different perspectives. Really look for, is this really going to work? I mean, a devil's advocate position, we'll talk about that in a little while on another episode, is really an important way to make sure you're thinking this all the way through. And consider what needs to stop before something new begins, an important trade-off decision. And don't keep something just because you got inertia on that former activity. It may be time for it to stop, and you just have emotional connection to that as well. So, needing to stop something might be the right timing, and this is the time to actually give permission for that new process to stop. So if you'd like to continue this conversation, join me every Tuesday right here on LinkedIn, or you can subscribe to Viral Healthcare on your preferred podcast platform. And also on Fridays, I have a 5-minute reflection where we talk and dive deeper into understanding maybe what you did or what you adopted or what you let go of, or even more. I'd love to hear from you. Please connect with me. You can connect with me on LinkedIn or other venues. I want to hear what's gaining traction in your organization, or what you've rejected, or even better, I'd love to have it when you started something and then, thoughtfully, officially, formally stop doing it. We didn't just let it fade away, we stopped doing it. I'd love to interview you, talk about it, and maybe even bring it to this podcast if you're interested. On the next episode of Viral Healthcare, we're going to take a look at your personal style. We're going to start going inwards instead of looking outwards. What are the personality characteristics? What is the decision-making style that influence you personally? And not everybody's the same. That's sort of the spoiler alert. You can't only look outwards. You can use these systems, but you also have to spend some time understanding your own internal influencers. Pretty exciting topic. We'll talk about that on the next episode. So I want to thank you for listening to Viral Healthcare. If this conversation is useful for you, share it with the colleagues who's navigating change. And if you would like to have more thoughtful conversations about the ideas shaping healthcare, be sure to follow the show. I'm Bruce Spurlock, and I'll see you next time.